meeting.
Yeah, I can't. Yeah.
It's wonderful meeting Professor
you,
Talley.
thank you.
I remember meeting Professor Talley once in Australia and then once in Canada. You had come to Paul Moyadi's unit when I was working there. If you remember,
Yes.
you spoke on duodenal eosinophilia there. And then subsequently, I met you in Calcutta when you had come for the APDW meeting. So, and I've been following your work, very interesting work related to the duodenal eosinophilia and other aspects of dyspepsia.
Well, thank you. Thank you very much. I really appreciate that. I look forward to coming back to India again sometime when this pandemic goes away, hopefully soon.
Yes, welcome back to India whenever the next opportunity comes in.
Okay. All right, so let me see. Okay, I think we can get started with the introductions and then, we'll have Dr. Talley start. We do have Dr. Sanjay Devtare, who's our president of the Indian Medical Association here. So thank you, Dr. Devtare, for joining. I think you're on mute.
Good morning, sir.
Yes.
Nice to be associated with Midas.
Thank you. Thank you.
Yeah.
So,
Yeah.
So, Dr. Devtare, if you want to, we thank the Indian Medical Association for collaborating with us for this event, and we sincerely thank Dr. Devtare for spreading the word and letting all the IME members know about the event. Thank you, sir. Thanks for your help.
Thank you, sir.
Okay, and I suppose we can get started with the introductions if everyone's okay. Yeah. All right. So hi, good afternoon, everyone. I'm Dr. Saurabh Mukhevar. It's a Sunday afternoon, and we have a wonderful event coming up now. We have Dr. Nicholas Talley from Australia joining in. Dr. Talley is a distinguished physician, scientist, and gastroenterologist with a special interest in functional and inflammatory gastrointestinal diseases. He is a distinguished laureate professor of medicine at the University of Newcastle. He has protected time for research and clinical practice. He's past president of the Royal Australasian College of Physicians, past chair of the Council of Presidents of Medical Colleges, former treasurer of the Australian Academy of Health and Medical Sciences, editor-in-chief of the Medical Journal of Australia, and a member of the NHMRC Research Committee and MBS Task Force. He has an outstanding, highly cited academic track record with over 1,000 publications. He's a CIA on a NHMRC CRE in digestive health and a chief investigator on several successfully completed grants. He has attracted funding of more than 15 million Australian dollars in the last 5 years. He's won several prestigious research awards, including a Distinguished Research Prize for GI Society of Australia, Newcastle Innovation Excellence in Innovation Award, and several other awards. He's been invited to deliver lectures and present his research around the world, and is considered an international authority in the field. So thank you so much, Professor Talley, for joining in. And we have eminent panelists today. And and we have Professor Usha Datta all the way from Chandigarh. She's the head department of gastroenterology at the Premier Institute in India at PGI. She has contributed immensely in the field of academics with 213 original articles, 8 chapters, 50 research studies, 6 funded projects. She's organized several conferences and mentored more than 40 MDDM students. And she's the founding member of Crohn's Colitis Foundation and Celiac Society of India. And she has over 38 international and national awards. Thank you, Dr. Professor Datta, for joining in today.
Thank you.
We do have Dr. Govind Makharia as well, who is the professor of gastroenterology and nutrition at the All India Institute of Medical Sciences in New Delhi. Dr. Makharia is a medical teacher with an experience of training more than 80 DM residents and students. She's initiated a young clinician program in India He's a medical researcher with almost 300 publications and several book chapters. He has a long CV, and I'll just try to highlight the most important parts. He's awarded the best paper 10 times. He's got several gold medals and has about 9 patents and grants. So thank you, Dr. Govind Makharia, for joining in today.
Thank you.
And we also have Dr. Ramesh Ruprai, who is joining us from Jaipur. Dr. Ruprai is a very senior, experienced gastroenterologist who is a director, former professor at Department of Gastroenterology at SMS Medical College in Jaipur, president of ISG, and in the past and has more than 100 publications and research papers in peer-reviewed international and national journals. So thank you, Dr. Ramesh Ruprai, for joining today. After Dr. Talley's talk, we'll have a common clinical scenario in dyspepsia, and that we'll be discussing with all our panelists. So thank you, Dr. Talley, for joining in, and I'll let you start the talk. Thank you.
All right. Well, look, thank you very, very much for having me. Please let me know if you cannot hear me properly or if anything goes astray. So pleasure to be here. I'm going to talk about dyspepsia management and also cover new concepts that at least I believe are likely to change practice in the very near future. Of course, my focus will be on upper GI symptoms, but as you'll hear, it'll cover more gut symptoms and problems as well as they're relevant to dyspepsia. So thanks again for having me, and I hope this will be of some interest to you. Now, why isn't my slides moving? Hang on a tick. There we go. These are my disclosures for those of you who would like to see these, and they're available on the slides in the talk. So Hippocrates said that all disease begins in the gut. And as someone who's now studying the microbiome and gut inflammation, and not just gut disease, but other disorders that seem to be strongly linked to gut dysfunction, including anxiety and depression and other systemic diseases, it seems to me Hippocrates may be proven more right than even he perhaps knew. So fascinating stuff, and certainly relevant. I have a case to start this off, and I thought this would just set the scene for what we tend to see very commonly in the West in terms of dyspepsia. So this is a 39-year-old woman who's divorced. She's a high-flying executive, and she presents with a history of chronic recurrent fullness and epigastric pain. The pain is postprandial, as is the fullness, although sometimes she gets pain on an empty stomach. She also reports some heartburn, some retrosternal burning, although this occurs more occasionally, and the pain in the stomach region is more predominant. She's not vomiting, but she's lost a small amount of weight over the last 6 months. She feels very full after she eats, very uncomfortable. She describes this as bloating, but she actually means she's got early satiety. The symptoms have been there for a long time, although worse recently, and these occurred after an episode of diarrhea and upset stomach. There are no alarm features, but she is anxious, and the anxiety seems to have begun after her gut symptoms began, not before, but after. She's been on a proton pump inhibitor, but it hasn't really helped her. She's had an endoscopy somewhere else, which was negative, but she's now come for a second opinion. She's been tested for Helicobacter, and she's negative, and the physical exam's completely unremarkable. So I guess, you know, the questions as a clinician you'd ask yourself is, what's the most likely diagnosis? What's the differential? And what am I going to do? And I hope my talk today will shed some insights into this. But this woman, based on this story, has classical functional dyspepsia, which is one of the most common diagnoses in patients who present with dyspepsia, at least in Western countries. The question about additional testing, we can talk about perhaps at the end of this talk, because there are lots of options and the value out of many of them is variable to low. And in terms of therapy, I'll also be covering therapeutic options, particularly for functional dyspepsia, as clearly this is the biggest group and some people feel the most difficult group, although I'm going to argue, in fact, this is not as difficult as you might think. So dyspepsia is defined in various ways around the world, and that's one of the problems with studies. The Rome criteria, though, focus well, they used to focus on epigastric pain or discomfort. Now the focus is on early satiety, inability to finish a normal sized meal, fullness, and or epigastric pain. But if you look around the world, dyspepsia is remarkably common. In some places it's more common than in others, but around about 10% approximately of the world's population report chronic dyspepsia, some countries more, others less. And the most common finding on endoscopy, if you endoscope these patients, is you don't see anything. It looks quite normal. So that leads to this consideration of functional dyspepsia. But I want to emphasize something that's really important, particularly in Western countries. These are data from the United States, a few years old now, but these are very consistent findings in studies of Western countries. And that is that symptoms of gastroesophageal reflux are very commonly also found with symptoms absolutely typical of functional dyspepsia. And early satiety, for example, is one of the absolute classical symptoms of functional dyspepsia, but it's also remarkably common in patients with documented gastroesophageal reflux. And so, classifications have separated out reflux disease and functional dyspepsia and almost presented the information as if these are quite separate disease entities that might overlap, but that's not relevant. I'm going to show you data which suggests, in fact, these diseases are part of the same disease spectrum. And that's new information that also can affect management potentially. If you endoscope patients, this is 151 studies from a few years ago, over 5,000 subjects included. If you endoscope patients, no matter what definition of dyspepsia you use, whether it's a definition like a broad definition that includes heartburn or the Rome criteria, which excludes heartburn, no matter what you do, most of the time the endoscopy is normal. Some cases have changes of reflux esophagitis, occasionally Barrett's esophagus in the West. Obviously, stomach cancer is what we worry about most, but it's incredibly uncommon in the West in general, although obviously there are places, and particularly findings in the East, which have much higher rates of cancer, and peptic ulcer. So basically, endoscopy normally is normal, and that's indeed the group that is often just then labelled functional dyspepsia. So how should we manage dyspepsia overall? What should we do if someone comes in with chronic and or recurrent early satiety, postprandial fullness, epigastric pain or burning? And we have a number of options that we can do in clinical practice. We could endoscope everybody. We could do that. And that's one approach. I'll talk about that in a moment. We could give an empiric trial of a proton pump inhibitor. And there's good evidence that PPIs reduce symptoms. Obviously, they'll help heal ulcers. They'll improve reflux disease. and they improve functional dyspepsia in a subset. So that's another approach you can take, and only test if this fails, obviously. Mind you, if they've got alarm features, most people would suggest doing a prompt endoscopy. I'll come back to that as well. You could do H. pylori testing and then endoscope infected cases. That's fallen by the wayside largely. Or you could test for Helicobacter and treat Helicobacter and reserve endoscopy for those who fail. And the benefits of this is you'll obviously help treat peptic ulcer disease due to Helicobacter pylori immediately, potentially. But of course, the disadvantage of this approach is with antibiotic resistance, even if they're HP positive, you may run into trouble with this approach. And then there are combination approaches where you'll give proton pump inhibitors and then test and treat if that fails, or vice versa. So what's the evidence? And indeed, the evidence is summarized here very briefly. Endoscoping everybody is the most costly option, at least in the West, where endoscopy is not very inexpensive. And of course, most times you don't find anything. And usually we don't biopsy in practice routinely, although you can if you wish. We'll come back to why I think that needs to change later in the talk. If you find esophagitis, that may change your management, but often you'll still give a proton pump inhibitor. Endoscopy misses non-erosive reflux disease. And there's good studies, a couple of good studies suggesting that endoscopy provides absolutely no reassurance for patients with uninvestigated dyspepsia. So while you might think you're reassuring your patients by scoping them, the data suggest you are not. So this has fallen out of favour, endoscoping everybody. We'll come back to why I think that probably might need to change in the future. In the United States, who do you scope? For example, well, the age threshold is 60 and above, or if you have alarm features, and the alarm features are listed on this slide. And of course, these characteristic features are meant to help you identify a higher pre-test probability of gastric cancer. So if you've got evidence of, you might worry about a gastric cancer, then obviously you want to scope them promptly. But if there are no alarm features, you hope that gastric cancer really is an unlikely possibility as a cause of the chronic dyspepsia symptoms in your patient who is presenting. So at the moment, the current US guidelines, which a number of other places in the world follow, are summarized here very briefly, and 60 is the threshold. Remember though, in places where, and in parts, and in certain ethnic groups where gastric cancer is a much higher risk, then indeed this age threshold is too high. And the data indicate really you should be lowering the age threshold if you are worried that they come from an ethnic group or are living in a place where gastric cancer is much more prevalent than the background of gastric cancer, for example, in the United States. There's data on the positive predictive value of alarm features, and basically their positive predictive value is very low. So even if you've got alarm features, the vast majority presenting with dyspepsia for the first time will be very unlikely, at least in Europe and United States and Australia, to have a gastric cancer. And so really, there's many studies that have shown this, including this one. And if you look at the clinical features, in gastric cancer, you can see indeed that there are features obviously that you worry about, and this is why these are alarm features that are listed in the textbooks and in the guidelines. You can see this, but as I said, the positive predictive value of these is really very low. So having difficulty swallowing or weight loss, even weight loss, very low predictive value of a cancer being the cause of the dyspepsia symptoms. But of course, as gastroenterologists, we always worry about missing serious disease. The age distribution in the United States is based on data like these, which show that the gastric cancer rate jumps up at around about age 60. That's why the cutoff is 60. It's totally arbitrary. And so in India, I'm sure the cutoff could be quite different because of the rates of gastric cancer in India and in regions of India. So, but this is the US data, and indeed a number of other guidelines around the world follow very similar cutoffs, although in Europe the cutoff is lower than 60, and in, as I say, in ethnic populations with high cancer risk, high background H. pylori rates in general, then the age cutoff is lower in the guidelines. So the management of dyspepsia really is summarized on this slide, the approach that is most often suggested, and this is separating reflux disease from other forms of dyspepsia based on expert opinion. And I'm going to argue, in fact, this is incorrect, but anyway, that's expert opinion. Alarm features and age. I haven't mentioned NSAIDs, but NSAIDs are associated with higher rates of dyspepsia, so you want to know about that. And if you reach a certain age threshold, local age threshold, prompt endoscopy is indicated. If, however, there are no alarm features, then you have two options in practice in terms of uninvestigated dyspepsia, and this is look for Helicobacter, treat Helicobacter and see what happens, or, and sometimes it's and/or, give a trial of proton pump inhibitor therapy, which is very popular in the West. H. pylori eradication, though, clearly is very beneficial in terms of the management of uninvestigated dyspepsia. So that's uninvestigated dyspepsia. Now I want to turn to functional dyspepsia. And it's very interesting. I found this paper from the British Medical Journal in 1910. And this paper, in my view, summarizes our state of knowledge until about 15 years ago. It even mentions gastritis, doesn't mention Helicobacter, but it mentions gastritis. It talks about functional dyspepsia, talks about motility disturbances, even mentions the microbiome, although that's not the term used, talks about fermentation, and talks about anxiety. These are all factors that we've identified and studied for many years in functional dyspepsia. But I'm going to argue we are now in a different era, and we have a much clearer picture of what might really be going on, which surpasses this work from 1910 and in fact work up to probably 2007. So let's talk about them. These are disorders of gut-brain interactions, functional dyspepsia, the irritable bowel syndrome. And this is the biopsychosocial model of disease. Now you'll notice that this model talks about early life and genetic and environmental factors, which I think are important in these disorders, although not very well described in the model. It talks about physiology disturbances, and then it talks about a two-way interaction between the brain and the physiology that leads to symptom presentation and outcomes. But the trouble with this model is it doesn't actually explain anything. It talks about interactions, correlations. It doesn't talk about the etiology of disease. It actually doesn't predict what you should be thinking about doing in terms of curing disease. And in fact, you could argue this model hasn't taken us very much further in the last decade or two. And I've certainly argued this, and I believe this model is actually out of date and should be relegated to ancient history. But you'll see why I think that as I go forward. So functional dyspepsia, as I've said, is very common. India is on this slide, which is great. These are data from 2020 on FD. And this is the global prevalence based on the Rome 3 criteria, which are very similar to the Rome 4 criteria for FD. And these measure the symptoms, early satiety and or fullness and or epigastric pain and burning. So you can see this is a very common disorder. Around about 10% of the world have functional dyspepsia, as I've said already. I also want to emphasize that functional dyspepsia and irritable bowel syndrome, particularly IBS diarrhea, interestingly, overlap more than expected by chance. There's a number of studies now which have clearly shown these two disorders must share a common pathogenesis because there's this intimate relationship between a subset with IBS and a major subset with functional dyspepsia. The diagram illustrates the 4 major symptoms of functional dyspepsia, which must be chronic or recurrent, at least for 6 months, and must be bothersome for a number of days per week, as listed on the slide. And you'll notice there are 2 syndromes, postprandial distress syndrome and epigastric pain syndrome, PDS and EPS. And this will become more important as I talk about the etiopathogenesis. Remember postprandial distress syndrome, because this is the most important subgroup, actually. It's the largest, and it's the subgroup we actually probably understand the pathophysiology the best. So we've done the epidemiology of PDS and EPS, functional dyspepsia, and we've done this by endoscopy. So in Sweden, for example, we recruited 1,000 Swedish subjects randomly selected from the general population, so a random study, 80% agreement rate into the study, very, very large acceptance rate. We found 1 in 5 had uninvestigated dyspepsia. 15% approximately had functional dyspepsia. That is, they had a completely normal endoscopy and they fitted the Rome criteria of the day. The majority had postprandial distress syndrome. Of course, there's an overlap as well. And this isn't the only study to show this. There are a number of others. There's an Italian endoscopic population-based study finding very similar numbers. There's also our work in Olmsted County in the United States at Mayo Clinic, also showing that PDS is the predominant group in the United States. There's an overlap group, of course, although interestingly, epigastric pain's a little bit more common in the US, at least reported to be more common by patients. Very interesting as well. Postprandial distress syndrome is increasing, at least in Sweden. First study I've seen, first good data I've seen to indicate that a subgroup of functional dyspepsia is actually increasing. The incidence is going up. And this is work, again, in random population samples. The data have been published a year or so ago. And I don't want to go through the details except to say epigastric pain is completely flat, staying completely the same. And it looks like these 2 syndromes are quite distinct. They're not the same disease entity. So again, PDS, postprandial distress, remember that one because it's highly relevant to what we need to talk about. And then this is a complex slide. I'll try and keep it simple though. 10-year follow-up of our work in Sweden. For example, if you had functional dyspepsia at the beginning of the study, then 43% of those with FD at the beginning still had functional dyspepsia 10 years later. 20% had developed incident, new onset gastroesophageal reflux symptoms. 10% or so had developed incident or new onset irritable bowel syndrome. And a few people had developed both IBS and GERD. In other words, these disorders that we think of as separate, functional dyspepsia, IBS, and GERD, they are not separate according to these data. They are intimately interrelated and must share a common pathogenesis. The traditional pathogenesis of functional dyspepsia is summarized on this slide. People talk about gastric acid, although gastric acid isn't increased in FD. Helicobacter, which is important, by the way, although in many cases H. pylori is not associated with FD symptoms. Failure of the stomach to relax. The gastric fundus fails to relax. This leads to pressure in the antrum. The antrum gets distended if the fundus fails to relax after a meal, and this can certainly induce early satiety. This does appear to be a real mechanism that is disturbed in FD. Gastric emptying can also be slow, although it correlates poorly with symptoms. And we know the stomach and the duodenum, particularly interesting, the duodenum is hypersensitive to balloon distension in functional dyspepsia patients versus control. So that's well-established data, and that's where we've really been until very recently, until this study actually came out about 15 years ago. So this is work that we did in our Swedish population-based endoscopy study. This was the study, remember, where we gave free T-shirts to a population who came in to get a free unsedated upper endoscopy. And most people we approached agreed to do this. And we not only looked into the stomach and duodenum and esophagus, of course, we also obtained biopsies from each area and blood from all of these patients. And one of our working hypotheses was we would find inflammation in the duodenum in functional dyspepsia. And in particular, we hypothesized we'd find increased duodenal eosinophils. And that's exactly what we found. We found eosinophils were increased in the duodenum. They could form clusters in some cases. They degranulated, which indicates they are potentially very damaging. Eosinophils that degranulated tissue damage the tissue. And you can actually see with the carbol chromatoscope stain, they actually degranulate close to the nerves in the duodenal submucosa and mucosa. And we found increased eosinophils were linked to postprandial distress syndrome, not very much linked to epigastric pain. Some link, but nowhere near as strong. This is work we've done in Australia recently, which has been presented at DDW just this year. I'm not going to go through the details. This study shows increased duodenal eosinophils, particularly in those with postprandial distress syndrome. We had good controls here as well. We also showed that the tight junctions, the small intestinal permeability is actually altered in functional dyspepsia. There is increased duodenal permeability in functional dyspepsia. And you see this too in children. This is work we did in children a few years ago here in Australia as well, also showing increased duodenal eosinophils compared with controls in functional dyspepsia. And, you know, a very clear signal there that others have also seen in the United States and elsewhere. Mast cells actually are increased. They're increased, though, in those who also have irritable bowel syndrome by Rome criteria. So we did find increased duodenal mast cells. They're also increased in FD, but less if it's only FD alone, at least in our initial study. I'll show you some more data about mast cells. They're certainly increased in functional dyspepsia over controls, but the eosinophils are more striking in terms of their increase in functional dyspepsia over controls. Although if you have IBS symptoms, more mast cells seem to be present. This has been independently confirmed in work from Leuven. This is Jan Tak's lab in Belgium. Very, very good group, a big group interested in functional dyspepsia. And they showed that major basic protein, where the red arrow is, major basic proteins are major constituent of eosinophils. When they degranulate, you release MBP, increased in functional dyspepsia, and tryptase, which is released from mast cells, also increased in their cohort, although their cohort also had IBS overlap. And really importantly, the nerves are damaged, and this correlates with the inflammatory infiltrate in functional dyspepsia. Beautiful work from this lab showing that in patients with FD, the nerves are structurally and functionally abnormal, which makes sense. This is a motility disorder, except it's probably driven by an inflammatory process. And this is our latest meta-analysis. This is taking all the world's literature presented at DDW this year, basically showing, I won't go through the detail, if you've got functional dyspepsia, and IBS, you have increased duodenal eosinophils overall, but looking at all the studies that have been published. If you've got only IBS, no functional dyspepsia, there is no increase in duodenal eosinophils, although the number of studies that have done that is much smaller. Mast cells are also increased in functional dyspepsia. And then I want to share this study also presented at DDW. I think this is a landmark study, although it has, like all clinical studies, its limitations. But here we took from secondary GI practice more than 500 patients who were recruited into this clinical study from 20 sites across the US. They had to fill in a questionnaire which included the symptoms of functional dyspepsia, as well as nausea, vomiting, diarrhea, and a few other things. And they had to score as having moderate to severe symptoms on this scale. So these were patients with chronic, moderate to severe symptoms, but were thought to have a functional GI disorder. They really were thought to have functional gut disease. And they underwent a standard endoscopy and biopsy protocol. 8 gastric biopsies, 4 duodenal biopsies, and pathology was read centrally. There was also a control group recruited who were virtually asymptomatic. Otherwise, they went through the same protocol. These were volunteers. You can see that 90%, over 90%, had either gastroesophageal reflux or IBS or functional dyspepsia as their clinical diagnosis. Remembering in the United States, functional dyspepsia is known to be underdiagnosed in clinical practice. Most of them are labelled IBS, some are labelled GERD. So, patients entered screening, 73% met the criteria. They were biopsied, the symptom criteria, and of those, using a cutoff that was defined as representing eosinophilic gastroenteritis, more than 30 eosinophils per high power field in the duodenum and or stomach, 45% of these patients had evidence of increased eosinophils in the duodenum and or stomach. The majority were in the duodenum. They also had elevated mast cells, although the mast cell cutoff that was used based on the literature was too low. Indeed, looking at the controls, a number of the controls also had increased mast cells by the literature's criteria, which is clearly incorrect. And so mast cells were increased, but only modestly. They were increased, though, in this population. And only 5% overall didn't meet our a priori cutoffs. A really remarkable study. Prospective, representative of GI practice, carefully done, and really quite striking data. So lots of information now that duodenal eosinophilia is relevant to functional dyspepsia in adults and in children. We also did some work looking at whether eosinophilic duodenitis led to incident reflux. And this is a study that we published a couple of years ago, which really showed strikingly you were 6 times more likely to develop symptomatic reflux 10 years later if you had eosinophilic duodenitis, whether you had functional dyspepsia or were a control. Doesn't matter. You had a significant increased risk of GERD according to symptom criteria. There's limitations of this work too, but it's enormously interesting. Suggests the duodenum may be a driver in some patients of reflux disease. That is a paradigm shifting idea, just like the duodenal eosinophilia mast cell story is a paradigm shifting idea. And then, even more provocatively, we've shown if you've got eosinophilic duodenitis, you're at higher risk of developing incident anxiety. And that's really striking too. This is not perfect work and the numbers are small. It's provocative, very interesting, needs to be proven, but my goodness, again, suggesting the gut may drive anxiety in patients, not the other way around. We've done some work too in the epidemiology area, looking at associations. We wondered, well, if eosinophilia is present, this is an atopic condition potentially, does that mean you're more likely to be atopic or even autoimmune if you've got functional dyspepsia and or IBS? And the answer is, yes, you are. You're significantly more likely to have asthma or skin rashes and other things that are atopic if you have functional dyspepsia and or irritable bowel syndrome. And autoimmune disease, striking, was also increased, suggesting both a Th1 and a Th2 lymphocyte response may be relevant in these diseases. We've also done some basic science. This is work in humans. We've done some work in all sorts of, in animals too, but in humans, there is evidence of, for example, delayed gastric emptying correlating with increased homing small intestinal cells, T cells. And this CD4 cells, this is very clear-cut. We've now shown it in 3 separate studies and indicates evidence in the blood of small intestinal inflammation, really strongly supporting the idea of an inflammatory process underlying functional dyspepsia, and also, quite frankly, IBS too, interestingly. And we've also shown cytokine release in functional dyspepsia versus controls. I won't take you through this. I'm nearly out of time. This is work from our lab, also presented at DDW, really showing both a Th1 and a Th17 and a Th2 response. This suggests, again, there's a complex immune activation process occurring in functional dyspepsia. This is not a pure motility disorder. Functional dyspepsia is not a functional gut disorder. Our data suggests it's an organic GI disease. What about treatment? Well, difficult issue. We know that diet will alter the microbiome. Diet can potentially be anti-inflammatory. We know a low FODMAP diet works in irritable bowel syndrome, particularly IBS diarrhea, and a gluten-free diet, which is a low fermentable carbohydrate diet, a low FODMAP diet, also works in IBS. And there's some limited evidence from studies in the literature that a gluten-free diet may also help functional dyspepsia, and possibly a low FODMAP diet too. We know that non-celiac gluten sensitivity, which is a condition, a vague condition, but a condition defined as gluten-inducing GI symptoms, often functional dyspepsia and or IBS type symptoms. We know that some of these patients also have duodenal eosinophilia. And even rectal eosinophilia has been observed occasionally. So this suggests, again, a common mechanism really driving symptoms, and the artificial division into non-celiac wheat sensitivity or a functional gut disorder, really, it's almost time to discard this, in my view. And this is a really interesting study. This is in IBS, but again, they gave wheat directly onto the duodenal mucosa. They used confocal laser endomicroscopy. They could see in real time the mucosa opening up, eosinophils infiltrating the gut, degranulating too in the duodenum acutely after a food challenge, particularly to wheat, but also a couple of other foods seem to drive this non-IgE food allergy. And that's probably what these conditions are in some cases, food-driven disorders. So diet really becomes an important approach. I want to mention smoking. Smoking's been linked to functional dyspepsia. There's evidence from post-infectious functional dyspepsia, just like our case. If after you get acute gastroenteritis, you can develop functional dyspepsia and or irritable bowel syndrome. And if you're a smoker, you're at higher risk of that potentially happening. And we've just published a paper this year showing smoking is a risk factor for postprandial distress syndrome, not epigastric pain, for postprandial distress. Smoking is a driver, at least in our studies, of potential disease with a dose-response relationship to smoking in postprandial distress. And this really, I think, has been shown for the first time most clearly by this recent study. And smokers have a higher duodenal eosinophilia in functional dyspepsia. We believe smoking may well be a driver of increased inflammation in the duodenum in functional dyspepsia. The message here is change your diet and also ask patients to stop smoking if they've got functional dyspepsia, just like we ask patients with Crohn's disease not to smoke. Smoking is associated with changes in the microbiome. Really interestingly, the changes you see with smoking are very similar to the changes you see in functional dyspepsia overall. An increase in oral organisms, most notably streptococci. I mentioned post-infectious functional dyspepsia and IBS. Here's a good study which really showed this so beautifully, although others have too. Basically a salmonella outbreak in Spain. So salmonella is not traditionally linked to upper small intestinal inflammation, but this study clearly showed there was an increased risk of dyspepsia and or IBS. Some people were unlucky enough after an acute gastroenteritis to develop both dyspepsia and IBS. And then small intestinal bacterial overgrowth, just to mention this, it's certainly been studied in functional dyspepsia. There is an increase in coliform organisms in the duodenum in functional dyspepsia. Remembering the breath tests often give false positive results. You can culture, though, the duodenal aspirate and look for coliform organisms. But remember, this misses all the other bacteria in the duodenal microbiome. So small intestinal bacterial overgrowth testing only tests a very small component of the microbiome potentially in FD. We've been doing some work to actually study the microbiome in detail in functional dyspepsia. We developed with collaborators in Queensland, driven by Gerald Holtman, Professor Gerald Holtman, a biopsy device that's aseptic, allows you to get material aseptically. We showed this works and gives you a slightly different profile with the aseptic biopsy over the non-aseptic and standard biopsy. And we showed there's a change in the microbiome in functional dyspepsia. This is dominated by oral organisms, most notably Streptococci. And this correlates with increased symptoms as well. So we're very, very excited about the microbiome in functional dyspepsia. This is another plot showing the differentiation of functional dyspepsia from controls. And basically, we've also done cultures of the organisms, anaerobic culturing, which I think has been a real advance in looking not just at the ecology, but looking at the bacteria themselves and their potential pathogenicity in functional dyspepsia. And we've got some really exciting data coming up in the very near future on exactly that topic. The Japanese have also found Streptococci are increased in functional dyspepsia. Small study from Japan, but very confirmatory and very nice to see. So they're the mechanisms. What about treatment in the last few minutes? This is the most recent algorithm, one of the most recent algorithms, which summarizes potential options in terms of treatment. And the American guidelines in particular really focus on find and treat H. pylori, give proton pump inhibitors, and if that doesn't work, consider a tricyclic and or possibly other therapy. A prokinetic is not favoured in the United States, but is favoured in Asia, and psychological therapy if this fails. So let's quickly go through a few treatment slides while I wrap this up. Proton pump inhibitors, they work. They're better than placebo. Here's the forest plot comparing proton pump inhibitors with placebo. The number needed to treat is 10. So you treat quite a few people to get a true responder, but still reasonably good therapy and certainly better than placebo. Interestingly, the subgroup that responds is postprandial distress syndrome, at least based on this sub-analysis from the latest Cochrane review. Not epigastric pain, surprisingly. Now, this is only a small number of studies, but regardless, it's very interesting. And then there are emerging data, good data, that PPIs suppress duodenal eosinophils. We showed this first in gut, a little paper in gut, and it was also shown in a paper just published from the Leuven group in Belgium, but the results are very similar. And we know proton pump inhibitors block eotaxin 3 release. They block molecules that lead to eosinophil attraction. It makes sense, potentially, they would reduce eosinophil counts. And at least I suspect, and others do too, that the reason proton pump inhibitors work is largely through partially suppressing duodenal eosinophilia. It's only partial suppression, though. And that's probably why they don't work as well as we might like. These are the data from Leuven, Belgium. Really, I won't take you through this. I don't have more time. But essentially a small study, not a randomized trial, but still a study that suggests that proton pump inhibitors do suppress duodenal eosinophilia. And I think that supports the work that we did a few years ago as well. They also suppress mast cells and improve small intestinal permeability. Neuromodulators and H2 blockers are other options that people talk about. I want to point out this is a most recent elegant analysis that indeed H2 blockers are a good treatment, and also neuromodulators in terms of the top hierarchy of treatments for functional dyspepsia. And H2 blockers, interestingly, also seem, at least in our hands, to work best in patients with higher duodenal eosinophil counts. And so this is a small study, but regardless, very interesting data, which suggests that really H2 blockers may not just work by suppressing acid, but may work through the mast cell eosinophil axis. H1 blockers also work in IBS, interestingly. So I think this idea of antihistamines being a potential treatment for functional gut disorders is starting to look more likely to be where we should be thinking about treatment in the future. And there's some recent work in Nature suggesting this might be mast cell driven, at least in IBS. We've used treatment with budesonide in a small randomized controlled trial. Overall, no benefit over placebo, but as eosinophils, well, as symptoms went down, eosinophil counts also correlated with symptom improvement, a reduction in eosinophils. So interestingly, this might suggest that indeed duodenal eosinophilia is a driver of symptoms. And then there's been some really interesting work with biologics, like, for example, anti-singlet 8 monoclonals. These apoptose eosinophils inhibit mast cells very, very effectively. There's a randomized trial in eosinophilic gastroenteritis, although it also included some patients with functional GI symptoms and high eosinophil counts in the duodenum and or stomach. And in this study, a clear benefit of symptoms and definitely a reduction in duodenal eosinophils, very striking reduction in duodenal and gastric eosinophils with this particular compound. So very exciting proof of concept data that treating eosinophils might indeed really be an important approach for functional dyspepsia. And then the microbiome work with rifaximin, the non-absorbable antibiotic, suggesting, at least in this clinical trial from Hong Kong, this is better than placebo, rifaximin. And of course, this would fit in very nicely with the microbiome data, although this particular study didn't look at the microbiome. And so this is work for the future, work that we're currently doing. So in summary, ladies and gentlemen, functional dyspepsia is a disorder linked to female gender, psychological distress, smoking, post-gastroenteritis, food substances, atopic diseases. But this all fits the working hypothesis that the duodenal inflammation is a critical part of the whole process. You'd expect if there's an inflammatory atopic process, you'd see this more in women than men. I've already shown you the data on anxiety and duodenal inflammation, and smoking and duodenal inflammation, and diet, and potentially its relevance here to duodenal inflammation. So it's a very exciting time because we've got a hypothesis that might explain all of the features, intestinal and extra-intestinal, with this duodenal hypothesis. And indeed, we've published this hypothesis in a number of places, including the New England Journal. And essentially, this is a summary of it all, arguing that there is a process that drives duodenal inflammation. And we think that process is probably driven by pathogens and or food antigens, depending on your genetic predisposition. You get an inflammatory process, you set up a disease state that fluctuates, as you might expect, with an atopic condition like this, and you get gut dysfunction as part of that process that can drive functional dyspepsia and or gastroesophageal reflux, even distal GI symptoms. It's a very exciting hypothesis. We continue to test this hypothesis, and at least so far, we think the hypothesis holds up very, very well. So look, thank you very much. I'm going to stop there and ask you for any questions or comments, and I'll look forward to the panel discussion. And thank you very much for agreeing to have me here today. Thank you.
Great. That was a fantastic talk, Dr. Talley. We thoroughly enjoyed it. It's great to see how the pathophysiology is evolving. And I think as a practitioner, we recognize that we are just doing patchwork with the prokinetics and the TCAs that we end up using. So it'll be really nice if we could get to the bottom of this, certainly. Thank you so much. What I could do is a couple of questions related to the talk I'll take, and then some things will be addressed in the panel discussion, and we will skip those questions for now. So Dr. Harish Darak is asking, duodenal eosinophils increased since 15 years or more in functional dyspepsia. What's the does steroid help these patients reduce inflammation? I think you did answer that.
So very good questions. We know postprandial distress syndrome's increasing. We know that. We do not know if eosinophil counts are increasing, although the rates of duodenal eosinophilia in the US were significantly higher than I had anticipated. So that was really quite striking. So perhaps they are increasing. We know eosinophilic esophagitis is increasing. So, you know, that's a much rarer condition than functional dyspepsia, but it's clearly increasing, at least in a number of places. So I suspect, yes, I suspect this is an atopic diathesis, actually, and we are seeing more. I think the way we're treating this at the moment doesn't deal with it as an atopic diathesis. We really give Band-Aid symptom therapy right now, which does help, but generally doesn't relieve the inflammation and doesn't certainly change the natural history of disease very well, to the best of our knowledge. Steroids is, besides the budesonide study I showed you, there are no other data. We clearly need to do a steroid trial. That is an obvious study that is needed. We want to give local steroid because we don't want to have systemic toxicity. We suspect in our study we didn't get good enough duodenal release. You know, we tried to deal with that, but that was one of the difficulties. We need proper duodenal releasing budesonide, and then we can run that study properly. And I would urge anyone interested in doing that study, please do it. Please do it. It'd be very exciting to see those data come out.
Actually, yeah, just on the 9th. So, Dr. Datta, if you want to go ahead, I was just going to make a comment.
I just have a couple of questions, Dr. Talley. I think it was a fantastic lecture, highlighting all the components of dyspepsia and summarizing it so beautifully for us. The question I have for you is, in India, CA stomach is still a very common condition, and 14% people present with CA stomach at less than 14 years of age, 40 years of age, and the 5-year survival is less than 6%. So do you think we should have an age criteria for endoscopy which is lower than the West? I propose that we should have it, instead of 55 years or 60 years, maybe 45 or 40 years, because 14% of our CA stomach are presenting at an age less than 40 years.
No, I obviously I'm not an expert on the Indian situation, but I completely agree with the general concept that if your takeoff of gastric cancer is at a lower age, like 40 or whatever, and that's certainly the case in parts of China and other parts of Asia, so definitely the case, then the age threshold needs to be lower. The West is different. They have lower rates of H. pylori, lower rates, certainly low rates of cancer. They see cancers in older people almost exclusively. So the 60-year-old cutoff sort of makes sense in the United States. Although even there are some ethnic groups, for example, from Asia, who have higher rates of cancer in younger people, and there the age threshold needs to be lower. So yes, I would agree with you. 40 sounds reasonable. In some parts of Asia, it's 35. As the cutoff, which is reasonable too, depending on the local data.
So Dr. Talley, I'm just going to have a lot of questions in the case. which will address some of these questions. If that's okay, we can start the case, and then that may address the questions along the way, if that's okay.
Dr. Mukhevar, can I just ask one very pertinent question for the Indian scenario to Professor Talley? It's a very common condition that patients have dyspepsia and endoscopy is done. There is antral gastritis, maybe some mild duodenitis, but H. pylori is negative. What are your views in managing such kind of patients?
So we're also seeing this in some cases. We've just done a study actually looking at gastritis and functional dyspepsia symptoms. So this is not the eosinophilic gastritis. This is, non-H. pylori negative gastritis, if you like. And we found, interestingly, if you had gastric body inflammation, not eosinophilia here, but sort of non-specific lymphocyte increases, that was linked to epigastric pain. Not early satiety fullness, epigastric pain per se, which was a surprise to me because I thought we wouldn't find any association. So that really struck me. H. pylori wasn't linked to pain, but we've known that for a long time. H. pylori probably drives its functional dyspepsia through different mechanisms, but anyway. We found some cases of post-HP gastritis. In other words, evidence they had HP, but they no longer had Helicobacter. And that might be some of the cases of antritis that you're seeing in India, at least some of them.
Okay.
So I think there's more to learn about this. I think inflammation, when it's abnormal, is probably a potential driver of symptoms, but we have a lot more still to learn even about gastritis, believe it or not, despite the tremendous advances with H. pylori and the knowledge around that. So, yeah, very interesting. And of course, duodenal pathology is poorly read by many general GI pathologists. They don't count eosinophils. They don't look for them properly. They just don't worry about it because their training says they don't need to. Their training says eosinophils are normal and therefore we don't worry about them in the small intestine. Well, my view is they should start worrying about them. They should start counting them. And if you start looking for them, it's amazing when you'll see them. You will see them if you look. But if you don't look, you don't see them.
Yeah. No, I agree.
Dr. Talley,
Yes.
up till now, there was a concept that PPI were useful for epigastric pain syndrome. But now the recent meta-analysis has shown efficacy of PPI in postprandial distress syndrome and the association with reflux esophagitis. How does the eosinophils in the duodenum are responsible for reflux in the esophagus? Any mechanism?
That's a very good question. We actually think what happens is there's a reflex pathway between the duodenum. The duodenum feeds back to the stomach all the time. Chyme comes down into the duodenum senses the chyme, feeds back to the stomach to slow things down or not. And in fact, that reflex pathway also can affect fundic relaxation. We think, and this yet remains to be proven, we think that duodenal inflammation, a change in the hypersensitivity of the duodenum, leads to an increase in fundic disaccommodation. There's a failure of relaxation from the duodenum, and that increases your transient lower esophageal sphincter relaxations. So we think there's a link between the duodenum, the fundus of the stomach, and of course the esophagus. And if we're right, that means that the esophagologists are going to have to move down a little bit into the duodenum, which would be very good for them, I think.
All right.
Thank you.
So just Ravi, if you could start screen sharing, and while he's doing that, just a word on the budesonide. We've used with Joe Murray. We published in the Red Journal our experience with while at the Mayo with open capsule budesonide for refractory celiac patients to ensure the availability of, the action of budesonide in duodenum. So Dr. Murray has had excellent experience, and we published that in the Red Journal. Perhaps that can be tried because the current budesonide formulation seems to release in terminal ileum. So probably not going to affect the duodenal eosinophilia.
Yeah, we use the budesonide with apple sauce. We emptied it in the apple sauce like Joe did with resistant sprue, that's what we did in the budesonide study I showed you. But as I said, I'm still concerned that we just didn't get enough release, enough covering of the duodenal mucosa to do what needs to be done. And to be honest, we just didn't have the technology at the time we did this study to really look at that carefully. So it's just something we need to do again. But I think it probably will work if we can get release in the right place.
Okay, thank you. Thank you. So we have Dr. Ravi Daswani, who's a gastroenterologist with us. And Ravi, if you can start the case discussion and we'll have questions. And we do have polls for the audience. So as we have questions with the panelists, we'll also launch the poll so the audience can vote. So it'll be interesting to see what everybody thinks as well. Thank you. So Ravi.
Yeah, good afternoon, everybody. This is a case. Am I audible?
Yes.
Yeah. So this is a 42-year-old female who had presented to us with symptom onset since 1 month. Her chief complaints were abdominal discomfort, nausea, bloating, and feeling of gas with eructations and early satiety. All these symptoms were worsened on a postprandial status, and she also had generalized feeling of being unwell. She also gave history of losing 2 kilograms of weight in last 2 months, which was clinically not significant. No history of GI bleed, no dysphagia, and there was no vomiting. She denied any history of consumption of NSAIDs or aspirin. She did not give any family history of GI malignancy. Neither there was any history of diabetes or hypothyroidism. We asked the drug history, and she did not give any history of consumption of PPI or H2RAs in recent 2 months. On examination, her BMI was 27 kg per meter square, which was obese according to the South Asian standards, and her physical examination was otherwise within normal limits. The basic lab evaluation was apparently normal, with normal sugars, thyroid function tests, as well as electrolytes and ESR. So we labeled the case as uninvestigated dyspepsia.
Okay, so you can go ahead next. So just a question what Dr. Datta pointed out. See, alarm features the utility in predicting malignancy. And I think what I was trying to get at with the question was really the Indian threshold where the cancer is in mid-40s is the median age, as Dr. Datta pointed out. So compared to the West, again, I think this was answered that perhaps our threshold should be lower compared to the Red Journal guidelines, which say 60 is a threshold. So I guess we could just go ahead with the next question, Ravi. Yeah. So in this case, what would you do next? Let me ask Dr. Ramesh Ruprai, and I launched the poll to let the audience also answer what they would do. So,
the most very nice question that as there are alarm feature is only 2 kilograms of weight loss in 1 month, though it's a very significant one, but the patient has not been consuming food with the fear of getting the postprandial fullness. So probably we have to overlook it, and we have to go forward because the features of burning sensation in the abdomen is not there. So I would still prefer that we must distinguish these patients into 2 groups, whether it is epigastric pain syndrome or postprandial distress syndrome. I would like to give prokinetics to this lady and try to see at the first onset that whether she responds to prokinetics or not. So that would be my take, and would not investigate her on the first go. We may go for a stool test for antigen for H. pylori and try to see what is her status.
Yeah. Dr. Makharia, how would you approach this? Sorry, you're mute, sorry.
Raising her hand so she can respond to this. Usha raising her hands.
Yeah.
Oh, sorry.
Yeah.
apologize. I didn't see you.
Yeah,
Sorry.
Govind, you can take it. My input in this is I would agree with Dr. Ramesh Ruprai that we should do a stool H. pylori antigen because we have a high incidence of H. pylori infection in our country. If H. pylori antigen is present, we eradicate it. If H. pylori antigen is negative, it is like a postprandial distress syndrome. So empirical PPI therapy for 4 weeks after H. pylori antigen would be a good approach. I would also like to look at the diet of the patient and suggest lifestyle and diet modification.
Thank you.
Govind, please.
No, I think the point is important that we'll see indeed a endoscopy because she has some amount of weight loss and new onset symptom. So this will be, I mean, this will vary. The practice of doing endoscopy will vary from center to center, but ideally such patients when there is history of weight loss may like to do endoscopy in these patients because the symptoms are more recent and with weight loss. Although we can say that the weight loss may be because of multiple reasons of not eating, as Dr. Ruprai pointed out, but also because we have been going through this pandemic time. I know this case is of the during pandemic or before pandemic, but anyway, there's a lot of anxiety in the society during this pandemic because of loss of job and multiple other reasons. So weight loss, in fact, in our outpatient, we find a lot many patients are presenting with weight loss and anxiety. So that could be one of the factors which might be playing in a weight loss. So certainly going more in depth to the history, and then looking at should I investigate this patient. But I'll tend to investigate this patient with this kind of background.
So at the just 1 minute, Mukhevar, if you find that H. pylori is positive, in this country, almost about 80% population is H. pylori positive. Would you like to give the treatment to all the patients who are coming positive with dyspepsia? Is there any good response to treatment? Because as far as I understand, the treatment, if given to them, you do not get a sustained relief in his dyspeptic symptoms.
I think, yeah. Saurav?
Sorry, please go ahead. No, please.
So the point is, as Dr. Ruprai has made a point, very relevant for our country. I think we have been living in the dilemma. And there are a lot of publications which say paradox that we have H. pylori in our country. Almost 60% of our healthy people will have a Helicobacter, slightly more in those who have a dyspepsia, but we don't have gastric cancer. I think this is a misnomer. The belief that our country do not have gastric cancer probably is a misbelief. And I think, and Dr. Kosa already pointed out that in the lack of real data from gastric cancer incidence in our country, probably we are missing this point. And therefore, we don't invest our research into H. pylori eradication in those who have dyspepsia. And to address some of these things, the Indian Society of Gastroenterology constituted a task force on dyspepsia to investigate some of these questions, which are very, very relevant to our country. We all go by today, by traditional teaching, that 80% of our or 60% of our patients have H. pylori. What do you get if you treat them, even if they have dyspepsia? But this question still remains at the stage of questions. We don't have answer to this, but this is, we believe this is a very, very relevant question.
No, thank you. I think it is a pro-carcinogenic agent. Highly probably. Yes, Dr. Datta. Yeah, Dr. Datta, please go ahead. You're saying?
Yes, I would agree that it's a WHO classified carcinogenic agent. If it is found, it should be eradicated. In patients with dyspepsia, the number needed to treat is 7 in reducing the symptoms. If the patient does not improve with anti-H. pylori therapy, it may be that we have not managed to eradicate. It may be that they are the 6 patients who are not likely to respond, but definitely the incidence of gastric cancer reduces once you eradicate H. pylori. In China, Taiwan, Japan, they go home to home to pick up H. pylori and treat it so that they reduce the cancer incidence. So in this, we have to follow these guidelines of eradicating H. pylori whenever it comes to our notice.
Right, agreed. So we have the poll which says empiric treatment would be selected by 58% of the audience. 42% would like to do some sort of investigation. All right,
Saurabh, can I make a point out
Yes,
here?
yes, please.
Since the Kosadatta made a point at treating H. pylori, and one should remember in today's time that resistance to clarithromycin has become a real challenge. And there are pockets globally that there is a resistance to clarithromycin, which is the #1 drug for choosing Helicobacter. 2 points out here that in India, there are pockets where there's a high resistance to clarithromycin, #1. #2, a lot of people use a combination, the single kind of formulations which are mix of multiple drugs in same form, and the doses of those are inadequate. So whenever you treat Helicobacter pylori, when you, as a clinician, you decide that I want to treat Helicobacter in this person, then use the right formulation, right doses, rather than using single pack doses, which are mostly they are insufficient. Therefore, treating those patients for giving treatment for Helicobacter does not guarantee that you have treated Helicobacter.
Yeah.
And I think we as a clinician should remember this point.
I think it's point well taken, because we are 70-80% probably at best in getting these eradicated. So I guess we can move forward. Dr. Datta.
Can I just make a quick point here, Saurabh? The point I want to make here is I want to endorse what Dr. Govind has said. Whenever we give amoxicillin, it should be minimum 1 gram twice a day. Clarithromycin 500 milligram twice a day. PPI again in full dose, say 40 milligram of esomeprazole or rabiprazole, 20 milligram BD. This should be given as a BD dose, and preferably we may consider adding bismuth. Bismuth is a very low cost therapy, and if we add bismuth, we will improve eradication rate in one go in these patients, and minimum of 14-day therapy. 10 to 14 days is what is recommended. 7-day therapy is inadequate. So I think the choice of antibiotic, the dose and the duration, and ensuring compliance and checking eradication is not done routinely. I would like to emphasize that here.
Yeah. No, thank you. I think point well taken. We did look at our data, and we've had about 70-80% success with amox clarithromycin. Probably we are in a pocket where it still works, but yes, bismuth should certainly be second line. So anyway, Ravi, you want to go ahead with?
So just before we leave, I just like to emphasize weight loss occurs in postprandial distress syndrome from fundic failure, gastric fundic failure. That's well described. So a little bit of weight loss can be consistent with that diagnosis. This patient's also got excess belching, if I'm not mistaken. And that could be an indicator of reflux. You know, people swallowing air can obviously belch excessively, but you can also induce it. So it's just a thought in terms of the overlap here. So it all kind of fits functional dyspepsia, but I'd still be worried about a H. pylori related problem. And I certainly would test in at least in my part of the world, we would test and treat if it's positive.
Right. Okay, so now as we chose empiric treatment, dietary advice, what's the routine dietary advice that you recommend in these patients? Dr. Datta, you had some opinion on that, yes.
Yeah. Dietary advice, I usually start with asking the patient what is the timing of their meals, what is the nature of their meals, and the quantity of their meal. Quite often I find once I ask the patient to elaborate that, there are obviously gaps in their timings of their meals, or late night meals, or eating out very frequently, and the nature of the meal is not the ideal one for the gut. So once I make them conscious of that, then they can schedule the timing and the nature and the quantity. So that's point number one. Point number two is quite often people have problems with milk. Second is people have problems with wheat. And third is that the patients have problems with, some egg or any kind of a protein like fish or egg or something like that. So here I try to just assess whether there's any food induced symptoms which are specific to any food. Then I try to advise them to avoid it for about 4 weeks, till the time the medications come on, and then they can reintroduce it themselves and see which one works for them. In general, we should not restrict their gluten unless they have definite gluten sensitivity, which is documented. Otherwise, milk can be replaced by dahi because it's a very important source of protein in our country. So whenever I write avoid milk, take dahi. So, you have to give them a good substitute. Dahi has probiotics as well as it has high calcium bioavailability and continues with the protein. So dahi is a good option in these patients, and timed meals would be a good idea in them.
Okay, great. Thanks. Ravi, the next question. PPI alone or PPI prokinetic? I think Dr. Ruprai did mention what he would want to do. You want to use a prokinetic. Dr. Makaria, if you're empirically treating these patients, would you use a prokinetic with PPI or just a PPI?
Just PPI, although there's a meta-analysis now suggesting that prokinetics do have efficacy in functional dyspepsia. But I would start only with PPI and then look forward. If no response, then add prokinetics to that.
Okay.
I would just put forward that there is mostly a overlap which is there. No patient has got alone a epigastric pain syndrome or burning, and other group does not have dyspeptic symptoms. In dyspepsia in India is almost about 60 to 70% population of functional dyspepsia. As Dr. Talley has also just mentioned that in the functional dyspepsia, the postprandial distress syndrome is much more common. So I think there is a lot of overlap which is there. So treating only with PPI is probably is usually not very successful in all our patients. This is my feeling.
Yeah.
So no data is there.
Sure. Yeah, and I've also launched the poll on the diet advice that you would do for these patients. So please feel free to vote, everyone. All right. Next, Ravi. Okay. Any specific PPI preference if you were to use Dr. Makaria?
Not really. All are we believe that all are same. Yeah.
Okay. Okay. All right. So just yeah. So just 1 second, Ravi. Before that, so we do just want to share the results of the poll. So I'm just going to let it end. Yeah. So looking at what the audience would do, this is you could choose any of these or many of these. So low FODMAP diet was 42% of the audience would do. Avoid gluten, 23%. Avoid milk, 44%, and avoiding spicy and fatty foods, 72%. So that's more popular. All right, thank you. Okay, so
you can ask Dr. Talley what is his opinion.
Talley, what do you think?
Well, I think there is some evidence for a low-fat diet because you certainly slow gastric emptying with a high-fat diet. So that's reasonable to consider. Spicy foods is interesting. There are some data that spicy foods actually might protect you, that they might actually be good for you. You may actually improve dyspepsia even. So I'm not sure about spicy foods. There's not a lot of data in terms of dietary interventions. And then I think low FODMAP, there are some data coming, some data from Hong Kong and elsewhere suggesting it may work, and a gluten-free diet's very reasonable. I like the idea of milk, eggs, etc., also being considered as potential antigens that drive disease. So very reasonable. So really, any of the above would be quite acceptable answers. And you probably should try different diets depending on response.
Yeah, and I do feel that it's so hard to study diet as a factor. So although we recognize its importance, but it's just not studied well, and it's hard to study. So, so I think that just leaves us in a bit of a tough spot there, and especially considering we do 6 food elimination diet for eosinophilic esophagitis, but then it's so hard to identify the diet. And I guess we'll encounter the same problem if you're investigating duodenal eosinophilia further. Yeah.
No, I completely agree. It is difficult, and compliance is an issue always. So
Yeah.
There's a problem.
Sort of for FODMAP diet, which is very commonly prescribed in Australia. So how much is the adherence to FODMAP diet? It's so difficult to eat that diet.
Well, it is difficult. Look, for IBS, we use a low FODMAP diet in some patients who will tolerate it. Remembering you give the diet for a period and then you reintroduce foods. You don't leave them on a low FODMAP diet forever. It's actually a bad diet long term, probably unhealthy. So you do not do that. You give it for a short period, a few weeks, and then you start to reintroduce foods to see what is really potentially driving symptoms. I think it's a rather difficult diet to use in practice unless you have a dietitian to help you. So that's a real problem. And I think we'll come up with better dietary approaches going forward, but that's where we are now.
All right. So we did ask the audience what would be their treatment choice. 56% would want to use a PPI and prokinetic. 32% only PPI, 6% would actually want to use a TCA, prokinetic, and a PPI, 2% SSRI or SNRI, and empiric H. pylori therapy 5%. So that was the audience breakdown. All right, okay. So Ravi, do you want to go ahead?
So the patient was counseled for lifestyle modifications. We advised her for avoiding fatty food and odd time meals, as Dr. Datta madam told. To consume high fiber diet and to consume small frequent meals. We also advise her to have a daily exercise routine, as her body mass index was above 23.5 according to the Indian standards. And we advised her to take rabeprazole 20 mg once a day for 8 weeks.
Okay.
On follow-up, after 2 months, the patient had 40% improvement in her symptoms.
Okay. So, all right, so we have improvement. Yes, Dr. Datta, yeah.
Yeah, I would like to add here that quite often patients are not compliant with the timing of PPI doses. Half an hour before breakfast gives you the highest bioavailability, and PPI has its own downsides in terms of side effects. So it is very important before we assess efficacy at 8 weeks to know whether the patient has been compliant and has taken it half an hour before the meal. So that's one thing. And also just a comment about the PPI prokinetic thing. If the symptoms of postprandial distress is very severe and disturbing daily life significantly, then we can add a prokinetic because there is some evidence, but otherwise PPI alone has been shown to be sufficiently efficacious.
Yeah, no, thank you. So at this point, the patient has partial relief of symptoms. We did mention the weight loss. Now, what would we want to do next? I have asked the audience to give their opinion. So we'll go through these things one by one. Ravi, next, yeah. Ravi, can you?
Yeah.
Yeah. So any role of ultrasound abdomen? Now we are in a prevalence, I think high chronic pancreatitis prevalence region. We do have enough gallstones around as well. So any thoughts on that? Do you guys find ultrasound helping you in these cases?
Yeah, coming in here again is that ultrasound is very important to pick up gallstones. Gallstones usually present with biliary colic, but recently we have analyzed data of 200 patients with dyspepsia and found that 50% of patients have gallbladder dyskinesia, because duodenum is the seat for the release of CCK, and if the gastroduodenal digestion is inadequate, CCK release is poor, and then they have secondary gallbladder dysfunction in the form of gallbladder dyskinesia. So definitely a screening ultrasound to look for gallstones is useful. We discussed about upper GI endoscopy. I don't think, except if the weight loss is very significant or there are any alarm symptoms, it is indicated. Definitely non-invasive H. pylori testing by breath test or stool antigen is advocated. Celiac serology, if we are in a high celiac area, especially in North India. In Southern India, they do not see so much of celiac, but however, a celiac serology can easily be done and is advocated.
Thank you. Next, Ravi. Yeah. So role of EGD, I guess we'll go ahead with that next. We did next, yeah. Okay, so we went ahead with abdomen, which was normal. Go ahead. Yeah, Ravi. Sorry, you can go ahead, Ravi. Yeah.
So we performed an EGD when my patient was still continuing for 20 mg of rabeprazole before breakfast. And we found that she had few erosions. There were multiple red spots, erythematous mucosa, and we decided to take biopsies for rapid urease test. We took biopsies from the antrum as well as from the body.
Okay, great. So just as we move forward, 68% would actually want to do EGD in this scenario, 15% ultrasound and non-invasive H. pylori testing, 40%, and 7% celiac serology. So it's, I think, visible to the audience. So yeah, I'll just.
Saurabh,
Yes, sir.
about the upper GI endoscopy, most of these patients who reach to the tertiary care, they have already received PPIs.
Yeah,
and
true.
they certainly would like to get an answer as to what they are suffering from. And it not only gives a patient a satisfaction. If it is normal, yes, they are satisfied that no big disease is there. If the doctor also gets satisfied that he has done it and he has proven to the patient and given a solace to the patient that he is not suffering from a big disease, because all those patients who have dyspepsia always have a concern of cancer and ulcer disease in their mind. I think I was going through the commentary of the dyspepsia in 2017, and the same question was asked to Dr. Moedin, and then he told that yes, most of the times the patient themselves ask for it, and it probably needs to be answered. So,
right. Yes, certainly.
what's your take?
A lot of people. Okay. Next.
So the rapid urease test came out to be negative at 30 minutes.
Okay. So
yeah, here I would like to say something is that a rapid urease test can be false negative in a patient who has been on PPI. So this is something we have to be very careful about. And second thing is rapid urease test is positive only when the number of H. pylori is more than 10 to the power 5 per ml of tissue or per gram of tissue. So when we give PPI, the H. pylori gets suppressed and that results in a false negative test. So we should be careful about this and maybe take it from the fundus or keep the patient off PPI for 2 weeks and then do the endoscopy.
Another thing is that there is a migration of the Helicobacter from the antrum to the body. So taking a biopsy from body is also important.
Yeah, no, I think point well taken. This is a routine clinical challenge we encounter. They are not willing to come off PPIs for those 2 weeks and then come for the endoscopy again. So I think probably need to alter our ways of getting the RUT probably from the body and more samples makes sense. Okay, next. So this question, that practical issue comes up. We should be checking in 24 hours as well, the current RUT tests. Dr. Datta, is that you recommend that to all your patients to go home and call?
Yeah, what we do is we keep a record in our own endoscopy room. We report it RUT at 30 minutes and then we keep the RUT and then we report it at 24 hours. So that's what is the ideal recommendation. But rarely ever we do find this coming up positive at 24 hours. So usually we go by the half an hour RUT. It is a good practice to give it to the patient. They can take a pic and send it to you the next day to know whether it is pink or not pink.
Yeah, I've seen a lot of patients have it turns positive later. So I guess that's good. Now the question now again, as you said, with PPI and H. pylori testing being a problem, in the West, when we were there, we used to do gastric biopsies for H. pylori, the Sydney protocol, 2 antrum, 1 incisura, 2 body. Now, is that, I guess it's a cost issue in India for sure, for, for private practitioners. So what is the advantage of, say, doing this in Indian context where, RUT sensitivity versus doing the 5 biopsies? Yeah.
Whenever we do an endoscopy in India, it is recommended that we do the Sydney protocol for 2 reasons. One is, if you have missed it on RUT, you can pick up even a few organisms on histopathology. Only thing, your histopathologist should be sensitized to pick up H. pylori, because it's such a common thing, they may end up missing unless they look for it. That's point number one. And the second thing is there can be intestinal metaplasia, which is a harbinger of future cancer. So it is a good idea from incisura to take a biopsy and request a pathologist to report whether there's intestinal metaplasia or not. And these two reasons, I would do a biopsy in these patients.
Okay. And just I'll add a question to that. And Dr. Robert Panakal is asking if in case of dyspepsia, if EGD is normal, should we do duodenal biopsy? Dr. Makharia, what's your practice? You're in a relatively higher prevalence area in North with celiac disease. Do you always do duodenal biopsies or not?
So we do duodenal biopsy in these patients if they undergo endoscopy, but we just completed a meta-analysis to look at the prevalence of dyspepsia. Prevalence celiac disease in those who have a functional dyspepsia, and we found that there's no increased risk of celiac disease in those who present predominantly with dyspepsia. So probably advising celiac serology is not justifiable at this point of time. But certainly you would do duodenal biopsy, as Dr. Talley already highlighted multiple times, that you not only look at the cryptophilus architecture, but also look at the duodenal dystrophilia. Although we don't know what the clinical relevance of this, even if we find there's a duodenal dystrophilia, what do I do out of that? Maybe we ask Dr. Talley that what would he do if he find in such patients eosinophilia?
So number one, PPI seems to work in this situation more often. So I do use PPI, and I might even consider a higher dose of PPI if initial therapy fails, at least as a trial. But that's a clinical decision. There's no real data to push that, but it makes sense. If that fails, I do try a H2 blocker, the old-fashioned H2 blockers, because again, in our hands, there's a benefit in that setting, and some people do respond. In fact, what we give is a H2 blocker with a H1 non-sedating antihistamine, H1 and H2 combination. And in our hands, that works in 70% clinically. And so we're quite impressed with those data. However, it's not been subject to an RCT. So I cannot tell you if it's just placebo. I don't think it is, but that's what we do. And thirdly, diet. I look hard for food antigens in a setting of duodenal eosinophilia. So not just a low-fat diet. I think about specific food antigens, wheat, milk, we talked about it, etc. So they're the three approaches I take simplistically. And most of my patients in clinical practice with FD get completely better, which is really quite worrying because I can't get them into clinical trials then.
How many eosinophils you consider significant?
Yeah.
Dr. Talley? How many
eosinophils? Sorry, say that again. How many eosinophils are abnormal?
Hi, how many?
Look, the cutoffs vary by country, and I think it's more difficult to tell you what the Indian cutoffs are. In our hands, more than 20 eosinophils more than 20 eosinophils per high power field is definitely abnormal. There's absolutely no doubt about it. However, the cutoff's probably lower for disease than that. But just remember the number 20.
Yeah, because for diagnosis of eosinophilic gastroenteritis, I believe it would be 50 or above. So
actually, the cutoff by the FDA has been 30, but some people have used higher cutoffs of 50. You're quite right. But 30 has been the cutoff used by the FDA recently. And if you use the 30 cutoff, that's the number we used for the US study with the 20 site study. We used 30 as the cutoff.
Right. And
in controls, we found 6% of controls had increased duodenal eosinophilia and 45% of patients presenting with chronic GI symptoms.
And Dr. Sunil K is asking which H2 blocker is preferred, famotidine versus
I don't know whether it matters. We've used ranitidine until it got taken off the market, then famotidine because that was available to us. And we use loratadine as the H1 non-sedating blocker.
Yeah. And just on the question of RUT to Dr. Datta, should the RUT be kept in fridge for 24 hours? I'm not aware of that. Sorry.
No, an interesting thing which I found is RUT should be kept at room temperature, because it is a bacteria which has to produce a chemical which has to be converted. So if you keep it in a very cold area, the reaction doesn't happen. In fact, I realized in our endoscopy room, because the average temperature is about 20, 22, the RUT was not coming positive. So then I shifted the RUT to a place which is warmer, and I found increasing positivity. So RUT should be kept in a warm area.
Right. Okay. Thank you. Next, Ravi.
So we did.
Go ahead.
So we did IgA TTG, which was negative. We plan to add a prokinetic. We would like to know the opinion of the house. Which prokinetic would be preferred?
And we have launched an audience poll as well. Any preferences for prokinetic? Any differences?
Domperidone has tachyphylaxis, so it is useful for a short duration therapy. It's fairly safe, except that it can increase in the prolactin levels. Levosulfuride has also been found safe. Etopride in our Indian population I have used extensively and never found a problem particularly. Prokilopride is more often used in colonic motility issues. Cisapride is banned, so we don't use cisapride. So my options are between domperidone, levosulfuride, and etopride. And there are these sustained release combinations which are also effective.
Yes.
I think the etopride has got a distinct advantage that it can be given for a longer time, and patients who have high diabetes is also very common in these group of patients with functional dyspepsia. So etopride works there also in controlling the glycemic control. We just recently published this article that etopride can improve the glycemic controls of the patient. So it is probably a good option, as Usha has also just mentioned.
Okay.
Ecosamide is also one which is recently launched. Actually, it's not been listed here, but I think if you want to use PPI together with pro-motility drug separate, I would also use ecosamide as because there are Japanese trials which have shown. In fact, Dr. Talley, what is your opinion? We would like to ask.
I think increased fundal relaxation, isn't? I mean, that's.
Yeah, these are fundic relaxing drugs. We don't have them in Australia. I know they're in India and in Japan, if I'm not mistaken. So I've got no experience clinically with them. I know the clinical trials were promising, small effect, but definitely better than placebo. So yeah, and they're fundic relaxers. That's how they work. And that's probably why they're beneficial. In fact, the prokinetics that relax the fundus, like cisapride, probably, I know it's banned, but anyway, that's probably the mechanism of action of benefit, at least for some of them.
Yeah. I think our audience seems to like etopride as well.
Yeah, especially those with postprandial.
Yeah. Please go ahead.
Yeah, I would agree with etopride as being a good drug in such a situation. Domperidone works well for short term.
Great. Thank you. Okay. So Ravi, do you want to go ahead? Yeah.
So we prescribed rabeprazole with domperidone once a day before breakfast for 4 weeks. Reassured the patient and counseled her for adherence to the lifestyle modifications, which we had explained in the previous visit.
So, all right. So when any role of doing motility testing at all, Dr. Talley, do you recommend?
Look, we clinically and also in research use the nutrient drink test. So we give them a standardized fatty liquid meal, basically Ensure, and we see whether patients have increased symptoms from an Ensure challenge. And that's very useful for discriminating functional dyspepsia from other things, actually, interestingly. However, it's not really a motility clinical test. Gastric emptying, we sometimes do. Its value in functional dyspepsia, unless it's incredibly slow emptying, is very limited. So I'm not sure, unless the patient is vomiting or losing a lot of weight, that gastric emptying is worthwhile. But if they are vomiting, it is worth doing a gastric emptying test.
Right. Well, okay. Right.
Yeah, I would agree here that if you want to test in patients with suspected gastroparesis, that is what Professor Talley was trying to say. If the patient has a lot of symptoms related to weight loss, repeated vomiting, excessive nausea, as well as predominant postprandial distress syndrome in a diabetic situation, there definitely we should rule out gastroparesis. And there I would like to use a solid gastric emptying time rather than a liquid gastric emptying time. In PGI names, we had standardized an idli-based gastric emptying time meal, which is now used routinely in our institution because it is a vegetarian meal which can be easily prepared with one of the idli powders, and it can be easily tacked to technetium and given as a meal. Otherwise, for non-vegetarian diets, we can use egg omelette or something like that. So practically, I would recommend a solid gastric emptying time if the patient has repeated vomiting, weight loss, or has a diabetes kind of a situation.
And Dr. Talley, would you like to comment on this technetium 99 study for the gastric hypomotility? How good it is as compared to the symptoms assessment? Means how many patients with really will have technetium 99 study positive?
So if you take a 4-hour cutoff, which is the standard in the United States and elsewhere, 10% emptying or less, approximately 20 to 30% of functional dyspepsia patients will have slower than normal gastric emptying. Typically, it's mild to moderate slowing, not severe slowing. But we've shown that that doesn't correlate well with symptoms, and others have shown this. There's debate about it, but I don't think it really correlates with symptoms, the slow emptying, unless you're vomiting or have severe weight loss. And we suspect the slowing of emptying is related to the duodenal inflammation as well. So to be honest, it's really a secondary mechanism, not a primary driver, we suspect, in many cases.
Yeah. And on those lines, Dr. Monish Sabra is asking, any role of electrogastrography? Do you use it?
So I can comment on that briefly if you'd like.
Yes.
So EGG, electrogastrography, is measuring the gastric slow wave, or it's trying to. So this is thought to be disturbed, and you get rhythm disturbances in functional dyspepsia. You do get rhythm disturbances. The gastric slow wave is disrupted in some patients, but EGG is very, very inaccurate. It's really problematic. You've got to measure it either by putting the electrodes on the stomach, or you've got to have a better mapping system. And there's a group in New Zealand who have developed a brilliant device for actually measuring this properly. So I think there will be these measurements in the future, but the classic EGG, I have stopped using. I have a machine in my cupboard gathering dust.
Thank you for that. All right, we can go forward with the case. Yeah.
So patient presented to us after 8 weeks. She had 80 to 90% improvement on therapy for the initial 4 weeks. She felt better. She discontinued the therapy and presented to us again after 4 weeks with recurrence of symptoms of stopping treatment.
Okay. So I always wonder, of course, duodenal eosinophilia being one thing, we're missing something, but next. So how about SIBO? Yeah, I mean, the Hong Kong study you mentioned, Dr. Talley, and there's some other evidence to support bacterial overgrowth, because especially in India, when they have such profound eructations is what I've seen. Is it dietary or is it SIBO? Any thoughts on that? Dr. Makharia?
No, SIBO is probably is much more common than what we believe.
Right.
And it adds to symptom complex of IBS-like symptoms and sometimes also dyspepsia-like symptoms. So that's perfectly fine. That SIBO is a common occurrence. I don't know how common in the general population. There's no data in the general population, but again, if you test a patient with IBS, you find at least 1/3 of them will have a SIBO, more often in those who have a IBS-D compared to IBS-C.
Yeah.
So, but I'm not sure we are going to treat those who have dyspepsia with antibiotic this point of time, unless they have predominant symptoms which are a lower abdomen rather than upper abdomen. This is a clinical dilemma. I'm not too sure about it that it's the right tactic, but this is what we practice. That those who have a lower abdominal symptom, I would consider SIBO as a more important clinical region for the symptoms. Also, to make a point that dyspepsia is heterogeneous. It's not only acid, and what we address now is only acid or maybe some eosinophils by acids, suppressing eosinophils infiltration by acid suppression. But we have not addressed multiple more mechanisms which happen simultaneously in a patient with dyspepsia. Therefore, response rate to any therapy will likely not be 100% in all patients.
Yeah.
The symptom response will be only limited the kind of therapy we address. If we want to treat dyspepsia completely, then probably we require a polytherapy, means addressing multiple pathways of its pathophysiology. Then we have a much better symptom relief. Maybe Dr. Talley have any response on that.
And also, I
Yeah,
just
actually.
Ali's responding. Also,
Yeah.
Sorry.
Is there any data, Govind, is there any data of SIBO and functional dyspepsia from India?
I think
Any idea?
I think there's a data, but I'm not aware of. There's a data from PGI by Dr. Rana, but I'm not aware of the finding of this data at this point of time.
Okay.
Yeah, and with the lactose intolerance being the other diagnosis, which is very common, I guess everybody thinks of diarrhea, but now we are looking at dyspeptics with bloating and eructations. So I believe there would be a certain segment of patients who are lactose intolerant, who have SIBO without diarrhea, and we are missing them and just labeling and treating them with this prokinetics. Dr. Talley, sorry, you are supposed to.
Yeah, there's not a lot of data on sugar intolerances in functional dyspepsia. There's data on SIBO. It's clearly increased in FD, but there's no data on lactose intolerance. The problem is that, well, not the problem, but even if you're totally lactase deficient, you can tolerate a small dose of lactose. So it's really, it just depends. There's also sucrase isomaltase deficiency that may also be relevant. So, sugar intolerance could be relevant in some people. And I think it's certainly worth thinking about clinically, although the evidence that treating lactose, well, removing all milk really will help in this setting. I think many patients don't respond to that, even if they're lactose intolerant. But anyway, it's worth a try.
Yeah, Dr. Datta, you were saying something, you raised your hand. Yeah.
Yeah, I was saying that in India, we do find a fair number of people having lactose intolerance because it is tropically a sun-rich country. So genetically, it has selected out a population which tends to be more often lactose intolerant. That's point number one. Second is milk. If we eliminate from diet, it can be a major source of protein and calcium loss. So that is the reason I said that we should substitute milk with dahi or curd, yogurt, whatever you may call it. The fourth point I wanted to make here is that many patients in India tend to drink hot milk. And hot milk gets emptied into the jejunum very quickly. And we did a study with hot milk versus cold milk, and we found that the hot milk gets into the jejunum very quickly and stimulates symptoms of lactose intolerance. So I usually advise patients to take cold milk in small quantity along with a meal so that little milk gets digested well. So usually for lactose intolerance, I don't test them. I ask them whether if they take 200 ml of milk, do they have any symptoms whatsoever? Okay. If they have symptoms, I give this advice to them to take care of their symptoms.
Yeah, thank you. And the subject of non-celiac gluten sensitivity, Dr. Makharia, any thoughts on that now that it's being recognized as an entity more lately, previously probably discounted by most?
That's true that there are a lot of people who have a sensitivity to not only gluten is a large protein, and the number of peptides which are immunogenic and they induce adaptive immune response. But some of the peptides do induce the innate immune response predominantly in the intestinal mucosa. Furthermore, the carbohydrate of the wheat, not only the protein part of it, the carbohydrate part of it can induce the symptoms of upper GI or lower GI. And not only GI symptoms, they can also induce multiple other extra intestinal manifestations, starting from headache to body ache to anxiety and all others are associated with non-celiac. But making a diagnosis of non-celiac is a real challenge. In certain countries, for example, in Australia or in the US, at least 20% of population, the data suggest that they go gluten-free, thinking they have their GI symptoms. Their GI symptoms are secondary to some kind of gluten sensitivity. And they would come back to you that I had these symptoms, I stopped wheat and I'm better. And this is how you make a diagnosis of non-celiac. But otherwise, somebody comes and you want to make a diagnosis of non-celiac gluten sensitivity. If the patient comes to you, you want to decide, does he have NCGS? It's quite challenging. The patient has to go gluten-free and give a challenge with gluten and look at response in the symptom. They go gluten-free, symptoms gets better, at least 30% of the symptoms gets better. Then you re-challenge, and again, the symptoms do reappear. That confirms non-celiac, and it's a challenge. Question also that although there are definitions of giving giving the diagnostic algorithm, but there is a lack of or non-availability of a standardized 6 grams gluten, which is recommended. You can give to these patients. So what people do slices of bread and look at response. But this is a thing still evolving. I think we'll have to wait for more time for a good clinical practice, but also keep in mind that some of these patients can have non-celiac.
Yeah, no, thank you. Okay, Ravi, to move forward. Okay, what would you do next? All right, now another challenge that we have. Okay, Ravi, 1 second. Can you wait? Yeah. So how long are you comfortable giving prokinetics? I've also launched an audience poll to let the audience respond. So any thoughts? And I mean, Dr. Ruprai, you did want to use prokinetics as mentioned. How long are you comfortable giving them?
In my clinical practice, I have been giving for more than 6 months to years also to these group of patients, because the moment I stop them, they start getting their motility dysfunction and bloating and things come back. And contrary to Dr. Usha's observation that domperidone has got tachyphylaxis, I feel that most of my patients do not have any non-response to domperidone, and they do good on a long-term basis also. I think I gave it for very long periods, and it does not have any. And there have been studies that domperidone can be given for 2 years and beyond also without any much of the side effects. So my take is that probably we can give for very long periods prokinetics.
Interesting. Yeah, and I think the main question is really the neurological side effects, which seem to be stated more, but actually are probably less in clinical practice. Dr. Datta, you raise your hand, please. Yeah.
Dr. Datta.
Yeah, I would give it for 8 weeks maximum. 8 weeks therapy, and after that I would like to taper off the domperidone. And in general, in patients with dyspepsia, I like them to come off medications as soon as possible. So by 8 weeks I would have reinforced the role of diet and lifestyle issues, and 8 weeks of therapy should usually do good in most of them. And if it doesn't work, just the H2 blocker works well in them. And I would not like to give prolonged prokinetic agents.
Thank you. Just on those lines, there was another question by audience here. How about cinetupride? I haven't really used it. Any experience with this? Any choice? Any preference? Dr. Datta, Dr. Ruprai, Dr. Mokharia, you guys?
Not used.
Not used. Okay. All right. Okay. So I'll just end the poll and share the results. So 53%.
So just maybe I should just say one thing.
Yeah,
I agree with the drug holiday idea, because you don't know if they're a responder or not. But I must say with prucalopride, they do get QT prolongation occasionally. So I do a baseline ECG, and I do think about that issue. So just remember that with prucalopride, not a problem with itopride to the best of my knowledge, but with prucalopride, at least a theoretical risk.
Mm-hmm. Okay.
Remembering that's what happened to cisapride. That's why it got removed from the market. It was QT prolongation.
Yeah. Thank you. Looks like most audience would want to use it for 4 to 8 weeks, 53%, less than 4 weeks, 24%, 8 weeks to 6 months, 11%, 9% are happy to use it for more than 6 months, and 2% not comfortable with them at all. All right. So move to the next question. Ravi, I think we did talk about acostamide. Go ahead, next. So now if we want to use tricyclic antidepressants, any thoughts on that? Dr. Makharia, do you use it much?
So that I want to make a point out here that dyspepsia, which is quite prevalent in the society, number one. Number two, the sensitivity to a symptom of individual. Many of them will live the symptom without complaining it. Many will overperceive it. And it's a very important clinical decision that not every time you keep running behind symptoms and keep adding more investigations and more treatment. If you have done a good first response to PPI, the patient responded, do well. If have responded to also to with domperidone treatment, did well, and you have ruled out any kind of organic pathology on endoscopy, and you have ruled out H. pylori, probably I won't go more at this point of time. Probably I'll give some more time before we address antidepressants. So probably give some more time because we know that the effect is never 100%. We are not targeting the one aspect of disease. So if those who have a symptom which persists, they are really bothered and bothered about symptoms, only then I go to second line or third line treatment, but not at this point of time. Probably I'll give for some more time drug holiday for a few weeks and then add on again PPI plus domperidone and look for response for 4 to 8 weeks. If they do well, nothing like it. If they don't, and they get worried about or they get bothersome about this symptom of dyspepsia, certainly I like to add SSRI at that point of time.
Thank you.
Dr. Mukhewar, Dr. Dr. Talley, in America, we have only metoclopramide. So how long do they use metoclopramide? Because they only have one agent available as prokinetic. We have several of them. How do they manage gastric hypomotility?
So in the United States, they don't use prokinetics, basically. Metoclopramide might be used sometimes, but there is a risk of tardive dyskinesia in the elderly, for example, as a risk. And of course, there's also cardiac effects. So metoclopramide's not widely used. You can get domperidone in the US, but you have to go to a compounding pharmacy. So prokinetics are not recommended in the US guidelines because of the problem with lack of availability. Tegaserod's back on the market. Tegaserod has a very modest effect in FD, shown in clinical trials, so I'm guessing that would be used. That's a 5-HT4 agonist. I just want to mention antidepressants. The randomized trial data indicate tricyclics probably work over placebo, like amitriptyline. SSRIs in the clinical trials, no benefit over placebo. SNRIs over placebo, no benefit. So that's the clinical trial data anyway that's available.
Yeah, thank you. Yeah, just
I think they should be used as a visceral analgesic because they're used in low dose. So if you want to use it in a refractory dyspepsia patient, it can be used as a visceral analgesic, and amitriptyline is of course preferred.
Right. Yeah, and
Yeah, can I just come in here? The meta-analysis, in fact, published by Professor Talley himself, has shown that among the psychotropic agents, only TCAs work. SSRIs and SNRIs don't work. So if at all you have to give, it is only amitriptyline or imipramine. Imipramine has been shown to have efficacy when you give at 50 milligrams for 10 weeks. So I assess whether patients have frank depression. If they have frank depression, then you go with the standard dose of imipramine. Or if they do not have frank depression, then a small dose, that is 25 milligram thrice a day of amitriptyline TCAs, help in visceral hypersensitivity. And this we try in patients with refractory dyspepsia, not as a first line.
Yeah, thank you. Okay, just on Dr. Ruprai's comment there, we used to send patients to Canada to get domperidone because that really seems to work in most of these patients, or they would import it from Canada. Because prokinetics are a wonderful drug for these patients, and it's unfortunate that there was really very little treatment options in the West when it came to that. I think we'll skip this one, Ravi. Do you want to move forward? Yeah. So, because there are a lot of questions from audience, we'll try to address them and then, get done with the session. So, yeah, Ravi. Okay. Thank you. So this patient was started on amitriptyline, continued domperidone for a while, and then was referred to a psychiatrist for evaluation, given concerns for some underlying anxiety and depression on clinical examination. So I'll just get through some of these questions from in the Q&A box before we end the session. I know it's been 2 hours almost. So Dr. Jayanti Venkatraman is asking, will PPI relieve bloat and early satiety? I think Dr. Talley did sort of allude to that with duodenal eosinophilia.
Yeah, there is evidence it improves postprandial symptoms, including early satiety. So yes, I think it does. The evidence is a little bit limited. It probably also improves pain. So I think you can use it as a dyspepsia drug with confidence in general.
And she's also asking any specific reason why there's a predilection of eosinophils towards duodenum. Is function dyspepsia now a type of eosinophilic gastroenteritis/duodenitis?
No, I don't think these patients have classic eosinophilic gastroenteritis because they're not typically atopic. They have atopic associations, but they haven't got an atopic disease process per se. I think it's in the duodenum because that's where the food antigens are most concentrated when they hit the small intestine. And so I think it's antigenic really driven. I also think there's an interaction with the microbiome in the duodenum that drives this disease. So I suspect that's the reason we see it in the small intestine, but occasionally it's just in the stomach. So, and then of course, we don't know exactly why that's the case, but presumably again, it's still food antigen.
Yeah.
Did you have the IgE levels in these patients, Dr. Talley?
They're typically normal. There has been some work done. We did some work in that US study, and we found IgE was generally normal. Interestingly, your peripheral eosinophil count, most people are below 500, but if you look at 250 and above, which is not abnormal, but is high normal, most of the patients have a slightly increased eosinophil count if you use 250 as your cutoff, which is quite interesting.
And then Dr. Rajendra Patel is asking, PPI blocks eosinophils. So how long PPI should be stopped before taking duodenal and gastric biopsies to look for duodenal eosinophilia?
Well, that's an extremely good question. I wish I had an answer to it. I don't know the answer to that question. Presumably weeks, but we don't actually know. But you're right, giving PPI will suppress them. So the fact you don't see them when they're on PPI is probably because they're on PPI, and that may well be what's going on in many cases in practice.
Right. And in our part of the world where there are intestinal parasites, how would that tie into duodenal eosinophilia?
Yeah, look, it's really interesting. We don't know what parasites are relevant or not. We do occasionally see giardiasis in the duodenum, which is linked to this. We've seen that recently, but we don't know how prevalent that is. I don't know about countries where there's a higher parasite load and what that means for this story. So it's a very good question. And the only places that can answer that are India and similar places where there's a bit of a higher load, and you could actually assess this issue, I think, very effectively.
Right. And he's also asking, like eosinophilic esophagitis does functional dyspepsia with duodenal eosinophilia can be treated with steroids or food elimination therapy. We did talk about steroids, but food elimination therapy, just like the S-fed diet for eosinophilic esophagitis.
We think the 6 food elimination diet probably works. We don't know for sure because we haven't tested it in an RCT, but we think it probably works. And that's a simple approach, although patients have to be compliant. So we need to do some clinical studies to sort this out. It's an obvious question to ask. The steroid story I talked about in the talk, and we don't know any more than the budesonide story that I mentioned.
Yeah. Okay. Okay. Dr. Devendra Singh is asking, which endoscopic lesion should be considered clinically significant in chronic dyspepsia? Any of the panelists or Talley, anyone? Which lesions would be considered significant? Like we do see antral gastritis, gastroduodenitis. So any relevant to that? As we sort of alluded to that a little bit earlier.
Yeah, I would think if I see any ulcer, so what I usually do is when I'm doing endoscopy, I look for erosions. I look for any features on NBI for intestinal metaplasia, atrophy of the stomach, duodenitis, and we look for NBI features of H. pylori gastritis. So apart from this, if somebody is more than 40 years, I would also look for features of early gastric cancer. So I usually always put on the NBI and screen the antrum, incisura area and body and fundus to look for any lesion which looks a little abnormal.
Saurabh, I believe the definition of functional dyspepsia means no endoscopic lesions. So would you like to mention here that if you label a person as functional dyspepsia, should there be any lesion in the stomach? Dr. Talley, to please give.
Well, it's a very good question, but the data suggest, obviously, if you have a peptic ulcer, that's clearly a cause of symptoms. A cancer is a cause of symptoms. Reflux disease, potentially a cause of symptoms, although I've already told you they overlap, so it's a bit hard to know. But if you just see a few erosions or a bit of redness, there's very little evidence that that is a cause of symptoms per se. So that's the problem. So I don't use the definition completely normal. I use the definition no ulcer, no cancer, no other major lesion. That's what I use.
And fantastic.
Great. We'll wrap up in the next 5 minutes. I know it's a little late. So Dr. Rajiv Hingorani is asking, is it necessary to add a probiotic in HP eradication? Dr. Datta, there is something available in market. Do you use it or not?
Sorry, just come again. Just come again, sorry.
Yeah. Is it necessary to add a probiotic in HP eradication?
Yeah, okay. Yeah, not as a first-line therapy. They can definitely take curd, homemade curd, but the cost benefit of adding a probiotic as a first-line anti-H. pylori therapy is not substantiated. So maybe as a second-line therapy, probiotic may be useful. So usually I advise 14-day therapy. After that, I ask the patient to continue to take homemade curd.
I want to add a point out here. If you want to eradicate, we need to do it appropriately, not like empirically using this or that. So if your first line treatment has failed, the well-defined second line treatment or third line treatment, where probiotic do not feature. So adding probiotic, you might add, but again, not for the reason of eradicating Helicobacter. The lot of drugs available in the market does not mean that we use them in clinical practice. And our objective here is to eradicate Helicobacter. We have a first-line therapy, we have a second-line therapy, we have a third-line well-defined therapy. If third line fails, in that case, you can try empirical therapy, whatever you want to do, but not before. So you will not like to recommend probiotic just like that in treatment algorithm of Helicobacter. It's always good to follow a clinically evidence-based treatment which are available. If not available, certainly one can do whatever the local experience suggests.
Yeah. Okay. So I think we'll just wrap up. It's lunch late.
Can I have a last
Yeah.
question to Dr. Talley?
Yes, yes.
Dr. Talley, any trials on eosinophil inhibitors like Montelukast? That's question number one. And why functional dyspepsia is more in females and smokers? Any explanation for that?
So there are some studies of biologic agents that inhibit eosinophils, and a lot of interest from companies now in this idea. I know of trials ongoing. We're just waiting to see where they land. It'll be very interesting. I think females get functional dyspepsia more often because they're more likely to have an immune activation response than men. Their immune system is more ramped up than men. We know that. That's normal physiology. And if your immune system's more ramped up and you have a disease process that is an immune disease, you're more likely to be a woman. So I think that's the explanation. And I think that the symptoms fluctuate because the disease fluctuates and the immune activation fluctuates, which also makes considerable sense. And then I've forgotten the third part of the question. Smoking, I mentioned as a driver of disease, either through the microbiome or possibly directly through the immune system, but we don't really know the exact mechanism, but it does seem to be relevant.
Thank you very much.
Great. So thank you everyone for joining in today. I think it's 2:20 and I think we've exceeded sort of our time by 20 minutes. So again, thank you so much, Dr. Talley, for joining in today. We really appreciate you sparing your time, and it was a fantastic lecture and wonderful discussion, and appreciate your inputs. Thank you, Dr. Usha Datta and Dr. Govind Makharia and Dr. Ramesh Ruprai. I think we really enjoyed hearing your comments. I think as simple as common as dyspepsia is, it's still like can still be a challenging thing to manage as we are trying to get to the bottom of things. But thank you so much. I learned a lot from you guys' comments and all your experience. So thank you so much. And so I think thank you. So I'll just stop the screen sharing. So next we have will be a week from now in the evening, which with Dr. Michael Wallace will be talking on artificial intelligence and gastroenterology. So you can follow us on our social media channels for more updates. We'll send emails out as well for anyone interested. So thank you so much. Again, I'll stop the session now. Okay.
Thank you very much for having me.
Thank you. Bye-bye.
Thank you, Dr. Talley.
Thank you.
Wonderful talk.
Bye-bye.
Wonderful talk.
Bye. Thanks.
Yeah.
Thank you.
Thank you. Thank you, Shrikant. Thank you.
Thank you. Thank you, sir.
Thank you.
So
sir.
nice of you.
Thanks for giving an opportunity to listen and participate.
Yeah. It was wonderful session.
Thank you.
Thank you, sir.
Thank you, madam.